Okay, good afternoon everyone. Welcome to today's Scrutiny Board. We're the Adults Health and Active Lifestyles Scrutiny Board. Today's the 11th of February. Just to remind people that this meeting is webcast online live, so just so you know that. I'm Andrew Scotes, I'm the Councillor for Beeson Holbeck and the Chair of this committee. I think we've got a really interesting agenda lined up for today, so look forward to everyone participating. I'm going to start as usual with a round of introductions. What we'll do is we'll start with board members and then we'll introduce people for the specific items shortly. Thank you. So, James.
Good afternoon, everybody. My name's Councillor James Gibson. I'm a councillor for Crossgates and Winmore Ward.
Good morning, everyone. I'm Emmy Bromley, councillor for Horsforth and Rawdon.
Good afternoon, everyone. My name's Councillor Mahalia Francis-May for Moortown and Meanwood.
Afternoon, everyone. Andy Ronshaw, councillor for Kirkstall.
Good afternoon. Councillor Kevin Ritchie, Bramley and Stanley Ward.
Councillor Raymond Jones from Horsforth, and I'm substituting for Councillor Taylor today.
Councillor David Blackburn, Farnley and Worley Ward.
Hi, I'm Jonathan Phillips. I'm co-chair of Health Watch Leeds and a co-opted member.
Councillor Conrad Hartbrook, Rothwell Ward.
Councillor Lynn Buckley, representing Old Woodley Ward.
Good afternoon, everybody. I'm Councillor Caroline Anderson. I represent Adel and Wharfdale Ward.
Good afternoon. I'm Angela Brogden, the Principal Scrutiny Advisor for the board.
Thank you very much. And I've had a notice from Councillor Kidger that she'll arrive late today. Okay, so I'm going to ask Angela to go through the first few procedural items. Thank you.
Thank you, Chair. So, firstly, under item 1, there are no appeals against the refusal of inspection of documents. Under item 2, there are no items for exclusion. And in relation to item 3, a summary note of the board's working group meeting in relation to children and adults neurodiversity assessments has been circulated as part of a supplementary agenda pack, and this is going to be considered as part of the work schedule agenda item. Under item 4, please may I ask if board members have any declarations of interest? And I shall take silence as none, thank you. And under item 5, we have apologies from Councillor Taylor, with Councillor Jones attending as substitute member. As the Chair mentioned, Councillor Kitcher's notified the board that she will be arriving a bit later. And we also have apologies relayed from the Executive Board Member for Adult Social Care, Active Lifestyles and Culture, Councillor Arif. Thank you.
Super, thank you. We'll move on to the minutes. So that's page 5 to 14. Firstly, can I take any points of accuracy on the minutes? Take silence as agreement. Great, okay. And then in terms of matters arising, Angela, can you start with the matters arising you've got? Thank you.
Thank you, Chair. It's primarily just to confirm that the information requests that were made at the last meeting have been addressed. This relates to minute number 71, Leeds Safeguarding Adults Board update. So further information has been shared with board members having requested further clarity surrounding figures relating to the mental capacity assessment performance measures and also an indicative time frame linked to the safeguarding guidance that's been developed with and for faith communities. And in relation to minute 72 performance update, board members have now received a detailed briefing paper from public health colleagues on the current position surrounding infant mortality rates. Thank you.
Thank you very much. Are there any other matters arising that any members want to raise or follow up on? No, that's great. So we'll move on. As always, if you want to write to me separately, that's fine. Okay, we're going to move on to item 7 next, which is an additional item which I asked to put in because there's been significant development here. For this item, we've got Councillor Venner and Jenny to speak to us. So I'm going to ask you to introduce yourselves and then comment, and then the next item is which everyone's going to be involved in, so then I'll let everyone else introduce themselves after that. So over to you, Councillor Venner.
I'm Councillor Fiona Venner. I'm the Executive Board Member for Equality, Health and Wellbeing. Do you want me to go straight into my comments? Or, yeah, okay, Jenny can introduce herself when she speaks. So this item is about the announcement of the funding of the new hospitals programme and how we respond to that as a city. So the government has announced 5 waves of funding, with the build for the LGI being in wave 2, which is 2030 to 35. Wave 1 is hospitals partially or wholly built of RAC and those that were where the build had already started. It is disappointing that our build will not start until 2030, and we as a council are taking this very seriously, which is why this is also going to Executive Board tomorrow. So I'm taking a paper about this to Executive Board tomorrow. And one of the recommendations of that paper is that we write another submission to the government about the importance of this build to try and bring forward the funding at an earlier point. For example, if there were underspends in wave 1, which, as I've said, is hospitals that are, it's mainly hospitals that are made wholly or partially of RAC. However, it's also important that we continue with the cross-sectoral work that has already started around the Innovation Village, which is part of this development, to enable this to continue to develop before the LGI build commences. So LTHT and partners, including us, are already progressing funded projects, such as the redevelopment of the old medical school to become an innovation hub for health tech. And the revised timetable for the hospital board will not, for the hospital build, will not impact on many of the innovations already in development, and the time before the build can be spent productively to support the regeneration of the area, which is part of the project. So I'll stop there, Chair, for introductory comments, and I'll hand over to Jenny to fill in more detail, and then we'll both be happy to take questions.
Thank you, Chair. Jenny Earhart, I'm Director of Finance for Leeds Teaching Hospitals and the Senior Responsible Officer for the New Hospitals Programme within Leeds Teaching Hospitals. So, sort of following on nicely from Councillor Venner, as we know, the scheme's been in planning and development for a bit over 8 years. We were announced as a priority in 2019, had various Prime Ministers come and visit. As with other schemes in a similar sort of position, there was a bit of a hiatus as the New Hospitals Programme was set up, and we've worked very closely with the New Hospitals Programme throughout the time period, and we've been a number of times said, you know, one of the most advanced schemes in the programme. So we are, as you'd anticipate, extremely disappointed with the announcement. Recognise, you know, as the Director of Finance, recognise the constraints around money, clearly. What we're doing now as a result, we're working across the organisation, but in the first instance at a senior level about, so what next? We've got a time frame for the build, but there are some things that we want to move more quickly than that time frame on. We haven't got a lot of clarity, I would say, from the New Hospitals Programme at this stage. We are still remain working very closely with them. I've got another call with them this afternoon. But we've put to them a number of elements of the scheme that we could progress in the interim, so that we are absolutely, you know, ready to go on the day that we get the money to actually put the big building up, if you will. But we are taking the opportunity to just have a small sort of step back and have we got the strategy right? Have we got the clinical services right? I don't think it's going to be a significant change, but given that we've been moving on this for 8 years, it is reasonable to say there may be something that will have changed in that time frame. I think, as you know, just to build on what Councillor Venner said, the economic growth element is something that's quite powerful, obviously for the city, but also from what the government's sort of aims are and what the government wants to support. And so that commitment to the Innovation Village, excuse me, the development of the old medical school, feels a really important piece that we really need to, you know, to push on with at this point. As I say, we've got an ask of the New Hospitals Programme around those kind of enabling works and early works that we can continue to do. We've had quite a lot of funding for that already, but to continue with that. And from a risk perspective, which is noted in the paper, we're working through those existing risks. We do have some risks that we had a mitigation of. We'll have a new hospital in this, you know, in a time frame. which we're now in the process of reviewing to make sure that those, it's reasonable to say that is now an extended time frame, or that we need to find a different mitigation. But that's the work that's ongoing at the moment. And where those resulting costs, we will be putting those back to the New Hospitals Programme, you know, as a this is a consequence of the decision, really. So aiming to continue that investment in the site, although it'll obviously be at a different time frame, but really key that we maintain that focus on innovation and economic growth. So happy to take any questions.
Super, thank you very much, Councillor Venner and Jenny. That's really helpful. So just to be clear, the recommendation is around us providing comment on this. I will allow questions as well. I think Councillor Venner said she's open to them, so we'll do that as well. But the point is we're making comment. Okay, Councillor, because this isn't a decision that we as a council or the local NHS can make. Okay, Councillor Francemeyer.
Thank you very much. I just wonder if you can tell me what strategies are in place with the delay of this build for those that are most marginalised in our city, but also with Leeds being a Marmot city, especially and for women as well. What's if you could tell me a bit more what's going on in the background to mitigate those? Thank you.
Thank you. So obviously one of the focuses of any NHS organisation is trying to minimise health inequalities, and as we work through what we do next, that'll clearly be, you know, really one of the key elements of how we go forward now. I mean, it's hard to say, you know, with the announcement having been the 20th of January, we haven't got beautifully formed plans since then, just because of time frames. But the minimising of health inequalities, addressing health inequalities, will be key to us developing those strategies and those clinical service strategies. I'm not anticipating that we'll have a whole-scale change in any of that, but it's been quite a period since we first wrote the strategic outline case and then the outline business case, or business cases plural, and so we've developed in our thinking sort of nationally, I think, but also locally around inequalities, and we'll make sure that that's taken into account as we do that development.
Thank you. We just wanted assurances, but thank you.
Thank you very much. Okay, Councillor Gibson.
Thank you, Chair. Yeah, so, I mean, it is disappointing, but, you know, on the other hand, it is good that we do have a guarantee that it is going to happen in 2030. I mean, we're sort of used to disappointment. We were promised it in 2019, and, you know, as you say, we've had lots of Prime Ministers turn up and promise us the world, but it's not happened. So why, but I don't know, there's been a lot of sort of bump in the background, you know, 40 hospitals and all that sort of stuff. So a lot of national conversation about hospitals that have been promised and haven't been built and the rest of it. So I'm not sort of over the top of the detail of all of that. Why, and you, I guess you're sort of in a good position to be able to explain a little bit why it didn't happen in 2019 when it was promised. What's happened? Why are we in this position now?
So there was a HIP, I think it was Hospital Improvement Programme at that time, and we were HIP 1, and there were a number of schemes that were HIP 2 at that point in time. That was reviewed, and I think not unreasonably, sort of more conversations about could we standardise as an NHS. Do we need to redesign a new hospital every time we want to build a hospital, or are there things that we should be doing sort of once and doing the same? So that's a lot of where the New Hospitals Programme came from in terms of that standardisation, modern methods of construction as well. So, you know, colleagues will perhaps understand that that terminology, but sort of doing as much building off-site in a sense as on-site. So the intention of the New Hospitals Programme was to try and manage cost and standardise, and I think there's a lot of positives in that. Unfortunately, what then happened was there's a sort of it just got a bit stuck, and I couldn't really tell you why it got stuck, but it got into a place where they've had a lot of policy, but the delivery's been slower, I think. But I don't know if Councillor Venner wants to comment on.
Yeah, I'll build on that. So the Darcy report that I think this board has seen that came out recently is very clear that the huge disinvestment in the NHS in the last 14 years hasn't only been in revenue, and in revenue where it's probably had the most devastating impact has been in primary care in terms of an actual reduction. But the Darcy report was also really clear that there's huge disinvestment in estates, and that's had a massive impact in terms of efficiency and you know, wanting to achieve net carbon reduction, etc. And as Jenny said, the New Hospitals Programme was announced in 2019, but there was a precursor before that, wasn't there? So this is why it's been going on 8 years, not 6 years, which takes us back to 2019. Of the 40 hospitals that were promised in the New Hospitals Programme, only one has been built. Although there's been, you know, it was announced with some fanfare. The visits to Leeds by Boris Johnson and Rishi Sunak were accompanied with quite a lot of fanfare about promises of when it was going to be built, which never happened. As Jenny said, the intention was there, but the deliverability never happened. And then when our government came into power, what was realised was that the money had never been there. And the review of the New Hospitals Programme was to put it on a sustainable footing so that we could rebuild the crumbling NHS estate that we'd inherited. Now, the waves are about levels of urgency, so that's why wave 1 is the hospitals that are wholly or partially built of RAC, and that's why we're in wave 2. We're urgent rather than very urgent, and also, as Jenny said, we are one of the most advanced schemes in terms of planning, which is why we're in wave 2 and not further down. So that's a bit more background.
So I suppose it's better for you guys to sort of have a concrete plan, even if it is 2030, than sort of, you know, get false promises that don't sort of amount to anything, and actually be able to start doing the work now to make sure that it is deliverable in 2030. I suppose that's better, really, isn't it, in the end?
I'd take that as a comment. Is that right? I think that's an opinion. Do you want to respond, Jenny?
So I think what we are working with the New Hospitals Programme now is to get that detailed plan, to get to a date, because as Councillor Venner said, the wave of funding is 2030 to 35. We expect to be building later than 2030 in the letters that we've had. The date is later than that. But the key thing for us is having that really concrete plan that does get us from here to there. So that's what we're working with the New Hospitals Programme on now.
Thank you very much. Okay, I'm going to bring in Councillor Blackburn.
I've got to say I share the disappointment shown by the exec member. As one of the members of the planning committee that saw the scheme and passed it, I'm very, very disappointed. But the question I've got is if any money does become available, have we looked at sort of scheduling it down the line? I've got to say I'm happy innovation centres still taking place, but I think it's if we can make sure that we're ready to go as soon as we get the money, I think that would help.
Yeah, absolutely. And I think out of the exec board's recommendations tomorrow, we're recommending that we do another submission to government, which is about obviously expediting the funding if for example, there are underspends in wave 1, which is not out of the question because, as I said, we're one of the most developed schemes. There are schemes in wave 1 that are not as developed as ours that may not, know where they're going to build yet. So if there are delays or underspends in wave 1, we're hoping that may enable us to be brought forward. Or failing that, as Jenny said, it's really important that we're at the front of wave 1. So we will, while we're not wasting time, while we're waiting for the build to happen, and we'll keep going with the innovation work, it's also really important that we keep in dialogue with the government and with the New Hospitals Programme about having a really concrete plan so we can start as soon as possible and hopefully sooner than 2035, which is obviously the end of wave 2.
Thank you very much for that. Okay, Councillor Ritchie next.
Thank you. and I too think it's a really disappointing decision and not good news for Leeds whatsoever. I do agree with dealing with the crumbling hospitals first. I totally understand that, but I would have preferred perhaps a wider wave one with Leeds included in that. I do think that capital investment is very different to revenue for government. I'm not an economist. I know that we're told often that there's no money, and they try to liken national budgets like a household budget, which isn't the case. And as you've pointed out, the economic impact of this fits into the strategy of more growth, but also triggering that wider economic impact from the innovation village. So my question on that is, you said that will still go ahead, but in the report it sounds like the hospital was going to be the trigger for that, unlocking that investment, and you did cite one example which is ready to go. So are we confident that those 1,000 jobs of 1,000 homes will still go ahead despite the delay in the hospital? Another question is, because again, one of the risks is the increased costs when we get to 2030. You've highlighted an estimate of 630 million. What is the current cost, just to give us an idea of what level of increase that is? I'd be interested in that if you were to start today, if you knew what the cost was, so what difference that's going to make. And then the two other risks that I point out, it's important to say it says at least 2030, so it could be after 2030. There's a general election before then as well, and anything can happen, as we know. New governments or a second-term government may review decisions, so I think that's another risk that we need to consider. Thank you.
So in terms of the innovation village, I think there are things that we can do now and that we're already on with. So the old medical school, you know, we're well into the conversations and the legal agreements and things around that happening, and that be a catalyst. We've got work to do internally about, are there other elements of the existing site that we could free up to in a similar kind of aim, but that's not, you know, that's an early conversation. And there are other pockets around the site as it currently exists that we could potentially free up for new build space as well. But the big area is where Clarendon Wing sits now. So you're right in the sense of we can't do everything we've written into the business case, because some of it was dependent on freeing up some of that you know, just land in terms of being able to build and put on a lot of jobs and a lot of med tech sort of innovation type companies. In terms of the cost change, so since we already would say, or we have previously said, had we been given the go-ahead at this point, the cost increase is about 300 million compared to the first numbers, you know, when we first sort of developed this. And that's the sort of the delay up to today. The further delay feels like about another 500. It's hard to say exactly because, you know, what does cost inflation look like in future years? But that's the kind of scale in total, about an £800 million scale compared to had we gone when we were first approved back in sort of 2019, you know, early. So the cost envelope that the government has set us is between 1.5 and 2 billion. Now, the most recent workings that we've done internally, assuming that we were going sort of now-ish, was just shy of 1.5. So there's quite a lot of work to do to say what does the design look like, because the design principles that the new hospitals programme have developed will be required in our build, where in the design that we've already got, it doesn't comply with those design principles because they didn't exist when we designed it. So there are quite a lot of changes that will need to happen for us to get to a point where we're building. But that envelope being so much bigger than our current estimate feels that they've taken account of that time delay resulting in cost increase. So that.
Happy? No, happy, but content with the answer. Good. Okay, Councillor Hartbrook.
Thank you, Chair.
Councillor Ritchie asked some of the questions I was going to ask, but just building on that. In your introduction, you said the increased costs would be passed back to the future hospitals building thing. Is that for information or for reclamation of the cost? Also, the increased cost which you've just gone through in the previous question, have you also done any modelling of the cost of lost opportunity, the cost of lost revenue from the extra houses that were built, the extra opportunities of economic activity that will be delayed or missed? What I'm building up to here is, I think everybody in this council, wants to see this hospital built and built to a good standard as quickly as possible, and to keep the pressure on as a city to the NHS and to those responsible for making decisions of whichever party to get the thing built for us as soon as possible. So I'm just kind of trying to tease out what levers in terms of negotiation we're trying to build an evidence base up to make the case as absolutely as strong as possible. The final point, in page 16 of the agenda pack, it says a lot on point 5 about how the plans will increase diagnosis capacity, and so a lot of better, more timely care. And I'm very cautious not to overplay this, but is it fair to say that if the hospital was built sooner, lives would be saved?
So I'll start with your first question and then come back to that. So the question around are we pushing the cost back to the new hospitals programme? So yes, we are pushing the ask to the new hospitals programme. These are very early days since the decision was made, and in fairness, they've got lots of schemes asking the same questions as we are. So we haven't necessarily got answers on those, but that's our as a trust, that's our intention. I think you make a really good point about lost opportunity around growth, and I think you might have seen in headlines, there's various press releases from other trusts where they've made a big play on the economic growth and been successful in getting some funding, not their hospital, one in particular is in wave 3 actually, so is well behind us in terms of the build, but has had some funding at this stage related to that that growth as we understand it. So I think you make a really good point. Our services are safe as we run them now. So are there risks that, building risks in particular that we would have taken out by having a new hospital? Yes. But our services are safe now, so I think it wouldn't be correct to say that, to give that sort of statement, because, we work very hard to make sure that we mitigate service risks and clinical risks, and we will continue to do that whilst, in the time frame whilst we're doing the build. So, thank you.
Thank you very much for that. Councillor Anderson.
Thank you, Chair. What you're asking Exec Board to do tomorrow is just to write to the government again. I don't think that that's going to cut it, really. I think we need to be on the doorstep week in and week out, banging the drum for the hospital. So what's the strategy there, apart from just sending another letter? The regeneration part of it is really, really important if we're going to get growth in the city. So that needs to be at the forefront as well. Thank you.
I'll start and then I'll pass over to Jenny to elaborate on the regeneration. We will continue to lobby the government as we have since 2019. I think it's worth stating again that the Labour government's been in power for 6 months. We inherited a crumbling NHS and the money for this programme was never there, which is why it was reviewed, so that it could be put on a sustainable footing, so that the estate can be rebuilt where it needs to be. We're in wave 2 because the hospitals in wave 1 are the ones that are likely to fall down because they're wholly or partially made of RAC. We will continue to lobby for the funding for this to be expedited. It's a recommendation coming out of the Exec Board paper tomorrow that we will continue to maintain that relationship with the government. We will do that as a council, so will our partners at LTHT, and so will partners across the health and care system in Leeds. We're all united in wanting this new hospital to be built as soon as possible, to the highest quality as possible, whilst also recognising the fact that the government is in an awful position in terms of the black hole they've inherited in the economy, a broken public sector, and a huge variety of competing priorities. With regard to the regeneration, as we've highlighted today, and as tomorrow's exec board paper goes through in more detail, there's lots of work around innovation that we're already doing. Leeds is already a centre of health innovation. There's more work we can do to build on that. There's more work we can do around the regeneration side of this project, and then I'll hand over to Jenny to say a bit more about that.
Thank you. So yeah, I mean, the work that's going on now with the innovation pop-up and the old medical school, but other projects that are a little less well developed, so we're not quite there in terms of it, sort of announcing them. I do think, you know, will help to drive that message of this or evidence the message that this big redevelopment will drive further economic growth. So absolutely, I think, you know, we'll see that in the coming probably couple of years with the old medical school, but then aim to maintain that sort of momentum as we go forward.
I know Councillor Gibson said, oh, well, we'll get it by 2030. We will not get it by 2030. It says it won't start until at least 2030. So by the time it's built, it's going to be probably 10 years from now. So, and as Councillor Ritchie said, anything could happen in between time. Thank you.
I take that as a comment. I think you're right. I think everyone said, yeah, if 2030 to 2035 is the frame, and then that's when we start building, yeah.
I just wanted to reiterate what I've already said, that yes, Wave 2 is 2030 to 35. Part of our lobbying strategy is going to be around making sure that we're at the front of that wave, and also pressurising the government to expedite funding if they're underspent in Wave 1. Thank you.
Thank you. Okay, Councillor Jones, it's my last one. If anyone else wants to speak, please indicate now. Thank you.
Can I just... It's 630 million now, and you expect it to be 800 million. Well, by that time it comes to when it happens. What's that based on? And the other thing that I would add is I think what should really happen is we should get Boris and co out here apologising to the people of Leeds for the disgraceful way they've lied about how they were going to fund the hospital. I find that offensive, and to be honest, if I was in the opposition party, I'd be totally embarrassed by it.
So there's a few different numbers bouncing around. So the 630 million relates to the cost of making good the buildings that we've got now. So the backlog maintenance, if you will, for the buildings that we've got running now. Yeah, yeah, it's a big number. So the 800 is the delay resulting in an increased cost of new build. The 630 is keeping the buildings going as we have them now. So just for clarity.
Thank you. Okay, so thank you for that. I feel like it's worth us making a few recommendations. I've made some notes while we're speaking, so it's maybe not as joined up as it might have been if I'd pre-planned a little bit better. But I think the things we want to say are we're disappointed about the time frame. I think everyone has said that, and hopefully that won't be controversial. I think we should also note that we're more ready than most schemes, and I think that's important to note in terms of the lobbying strategy, which has again been said several times. I think, again, this has been said several times, we support the exec board and LTHT working in partnership to do everything possible to bring this forwards. Again, I think that's something that everyone said, and I think everyone in this room wants to happen. And then the last thing I think is worth commenting on is that we welcome the meanwhile work and support that being done as fully as possible. So the stuff around the Innovation Hub, all that sort of additional innovation stuff needs to be done as much as possible and fully as possible. So I guess that's my proposal to the board in terms of our recommendations. I know we've just gone through it, so there's not been a lot of time to process it all, but it feels like, given we are a board, and this is a pre-decision meeting effectively because the decision will happen at exec board tomorrow, feels like this is a good opportunity to do that. So I'm seeing nods around the table, so unless anyone disagrees, I'll those will be the proposals or recommendations made from this board. Good. Okay. Done. Okay, we're going to move on to what was going to be the first substantive item of this board. So those who've come, I'm sorry you've had to wait. I hope you'll understand that we had to put that additional paper in because of the national significance of the hospital's programme. So what I'm going to do is I'm going to start by introductions for the people who haven't introduced themselves yet, and then we'll move on to the debate. And what we're going to do, if it's okay, well, what we're going to do is we're going to take each of the three sections separately. So we'll look at dentistry first, and then GPs, and then the LTHT stuff. So, but we'll start with introductions. So I'll start with Victoria, and we can work around the room. Thank you.
Thank you, Chair. Good afternoon, everyone. I'm Victoria Eaton. I'm the Director of Public Health at Leeds City Council.
Good afternoon. I'm Caroline Barrier. I'm the Director for Adults and Health at the Council.
Hi, Kirsty Turner, Associate Director for Primary Care at ICB in Leeds.
Hi, I'm Sam Prince, Director of Operations at Leeds Community Healthcare.
Good afternoon, I'm Alison Corns. I'm West Yorkshire ICB Dental Programme Lead.
Hello, I'm Jane Moore. I'm the West Yorkshire Local Dental Network Chair, and I'm also the Chair of the Managed Clinical Network for Urgent Care and a practicing dentist.
Hi, I'm Munaf Qayyum, practice owner, dental practice owner in North Leeds and the Leeds LDC Chair.
Afternoon, my name's Tim Hiles. I'm Deputy Chief Operating Officer at Leeds Teaching Hospitals.
Super, thank you very much and welcome. Can I just encourage you all just to bring your microphones a little bit closer? We're really keen to hear what you're saying, and I'm sure the many thousand people watching online will be as well. Helen, do you want to introduce yourself as well? Thank you.
Should know by now. Hi, I'm Helen Lewis. I'm the Director of Integration at the ICB in Leeds. Thanks.
Great. So we're going to move on to the dental part of the pack. So that's pages 23 to 32. I'm going to start with Councillor Venner to make some introductory remarks, and then over to you two on the other side of the table. Thank you.
I'm only going to say a couple of sentences, as these aren't papers that are generated within the council. The only point that I wanted to make was on the dental paper, actually, which was that when we had this subject at scrutiny before, Chair, I think it was before your time, I think it was when the Lord Mayor was still the Chair, we had really powerful testimony of lived experience in the board, which was facilitated by Health Watch, because they've got a lot of data in terms of personal experience, qualitative feedback around people's experience of accessing dentistry. It was really powerful. And I thought it, because I'm sure this issue will come back to this board, I had a suggestion that it might be helpful to go back to Health Watch to ask if they've got any updated feedback about people's experience since the commissioning changed. So I think it would be really interesting to get feedback from citizens of Leeds about if they're having a better experience with all the initiatives that have been put in place. Those were my only comments, Chair. I'll hand over to our guests. Thank you.
Thank you for that. That note will be taken forward and we'll see what we can put in for future. So thank you for that. So thank you very much for having us here today. As you know, in April 2023, West Yorkshire ICB took on delegated responsibility from NHS England for the commissioning and contracting of NHS dental services. West Yorkshire ICB have agreed to deliver the dental commissioning responsibilities via shared arrangement hosted by Humber and North Yorkshire, with South Yorkshire also. And approximately 2 years on from this report sets out a national update on dental services in Leeds, providing a focus on services at local and at national direction for the future of NHS dentistry. As you can see, we continue to deliver dental services across Leeds for primary care, community dental services, intermediate minor oral surgery, urgent care, orthodontics and secondary care. And while West Yorkshire ICB have the remit for commissioning dental services, local authorities have statutory responsibility for oral health improvements, including commissioning evidence-based oral health improvement programmes to meet the needs of the local population. Both nationally and locally across the NHS dentistry, there's a challenge with issues identified relating to the national contract itself, workforce gaps and procurement restrictions making it very difficult to secure new dental provision. And it's important to note that dental contracting takes place within the national context and challenges are well embedded, meaning that West Yorkshire ICB have many issues to overcome in its aim to improve dental services, but it's one that we're committed to. Improving access remains our absolute priority for the ICB, and since assuming delegated responsibility for the commissioning and contracting of dental services in April 2023, West Yorkshire ICB is working hard to improve dental services for those living in the area, and we're building positive relationships with the profession, local dental practice, and we continue to improve services. In Leeds in 2024, the ICB has so far increased the number of staff of the dental team so that we can work effectively to support the local dental providers to secure and stabilise dental services. We've developed positive relationship with our local dental committees, LDCs, to seek an input into future developments. And we've invested non-recurrent funding into various initiatives, looking at different health inclusion groups and trying to meet the needs of the population of Leeds. We've included increasing urgent care appointments and increasing orthodontic appointments. We've increased urgent care appointments. We've now got 15 practices in Leeds, now offering approximately 24,848 appointments throughout the year. We've got 5 sites in Leeds for orthodontics, 2 of which sit in GDS contracts. We've increased our homeless sessions, which we started 2 years ago under a pilot, and that now is well embedded into Leeds and working really well. And that would be something that would be welcome to share with you, because we have got some really good data on that from anecdotal evidence from patients which we could share. We've started an asylum and refugee sessions for 2 sessions a week in Leeds. We've increased domiciliary sessions to 3 a week, and we've got child 0 to 17 sessions focusing on child health inequalities and trying to meet the needs of the patients within schools and reaching out to families that don't access dental care. And we're also working on a safe discharge for cancer and bisphosphonate patients. In addition to the above investments in improving dental access, the ICB have also committed to continue its approach to flexible commissioning, which enables dental practice to work differently and prioritise access to the most vulnerable. Through offering community outreach sessions, dedicated clinical appointments, flexible commissioning practices are able to focus on both health prevention and treatment. There are currently 18 practices commissioned in Leeds across the patch, and we're working with those to increase over the next year, starting from the 1st of April this year. The ICB has invited practices to deliver up to 10% additional to their core contract. This is above their usual terms and conditions, and the incentive encourages practice to work above and beyond contracted levels with the assurance that the ICB will pay for the increase in activity. 22 practices across Leeds have applied and are currently working towards this, and the results will be known in 25-26. And the ICB are working hard in planning to transform the delivery of community dental services. Community dental services, or CDS, provide dental care for adults and children with additional needs and those from vulnerable groups whose needs cannot be met by general dental services. And the Leeds Dental Community Service provide the dental CDS under the Leeds locality. The aim of the CDS is to improve their oral health and reduce inequalities for people and look at their medical, physiological and emotional or social impairment and disability and work with them to include that they've got access. So under the current arrangements, we've now gone through a procurement, and we're pleased to say that the 4 CDS providers within West Yorkshire, including the paediatric service that was currently at Clarendon, will all become one under one lead provider from the 1st of April this year. This will mean that we've got fully staffed arrangements, we've got the fluidity of moving patients where we need them, making sure that they can be seen in the right place at the right time. And under this collaboration, we are really pleased and looking forward to what we can deliver in the future on this. Given the current challenge and the need to prioritise urgent care, there is most need further work to take place and review and assess the oral health needs across the population, and we continue to work on this as we go. Looking at the national and incentives and programme, we continue to deliver this, as well as our routine care and the additional non-recurrent incentives that we've done. We've looked at enhanced rate to enhanced rate of pay to see new patients. The new patient premium aims to encourage dental practices to see patients who have not been to a dental within the last 2 years. Nationally, the programme is being evaluated to determine the impact of the scheme, and we are awaiting this data. We've looked at a golden hello for practices, and this will mean that practices in areas of high deprivation are allowed to apply and see if that they can bring people in, so that we're looking at the workforce and give them a recruitment incentive to stay there over time. And maintaining the ring fence on dental budgets has been high priority, so that funding for dental services remains in place and focused on improving dental access. Overall, the NHS dental service remains a complex, challenging area. However, West Yorkshire ICB, in partnership with local authority colleagues in dental providers, is working to bring about improvements. A revised focus on improving access to dental treatment through the increase of appointments, combined with a focus on workforce initiatives and prevention. Data sets out in appendix shows the impact of some of this work that we've done, and together working in partnership with local authorities and our dental providers, West Yorkshire ICB is positive that we continue to invest in dental services to improve the needs of the patients. Thank you.
Jane, do you want to comment or at this point?
Obviously, happy to take questions. We have been working extremely hard, as you can see from the programme outline that Alison's just given. The plans for next year are to continue to increase access, particularly looking at inequalities. I'm particularly proud of the homeless programme that we have got up and running, which has now been rolled out across the rest of West Yorkshire. Leeds was the start. And Munaf actually runs some of the practice-based sessions in Leeds, so he'll be able to talk about that. My sort of one of the things that I really want to improve for next year is the communication between GPs and GDPs to provide a route for GPs to refer patients, particularly oncology patients and patients who have comorbidities that need urgent dental care. So that's one pathway that I'm particularly keen to get going and improve. Happy to answer any questions that people may have.
Yeah, since April 2023, since the ICBs have taken over care of dentistry from the NHS England, we have had a much better relationship with the managers and the contracts managers. With NHS England, they were very adversarial and quite aggressive with practitioners, and practitioners didn't like any contact with them, and they weren't very cooperative or helping practices, whereas now the ICB is looking forward, and we're lucky in West Yorkshire that we have got such a good team. The projects that Alison's mentioned, the homeless project, I've been involved with myself for the past 2.5 years now nearly. And at first I thought it's just helping a few people get teeth where they can't get access, but we're making a difference to people's lives. I'm seeing people coming in who they've gone through programmes at St George's Crypt, so they've come off the drugs. They're ready at a stage where they're ready to enter society again and they want to get jobs, but they go and they smile and instantly person's taken a negative view of them and that person's not going to get that job. So I've seen patients coming through. We deal with a few different groups where either they're just in pain and they want to get out of pain, so we deal with that. Others get a more full course where we're doing extractions and fillings, and for the ones who really want and they're dedicated and they come back for the appointments, we're making dentures and full rehabilitations and crowns and bridges for these patients. And it's nice when you see someone and then 6 months later they come back in for the review, because after they've been on the programme, I do accept them as a regular patient, and it's nice to see them again and see that they're back in society, they're working and they're seeing the family. So the programmes that the local ICB is working on is making a difference, and hopefully the asylum seeker programme that started, that'll be doing the same. The domiciliary visits that we've got, also in Yorkshire, the 110% I'm not sure if you know, but practices, we couldn't just, if I wanted to see more NHS patients, it's not a simple of matter of I've got an extra chair, get another dentist and see more patients. I'm physically not allowed to see any more patients than I do. I'm contracted to do a set amount of work each year. So whether you have 4 dentists doing that work, you'll get it done in 8 months, or if you've got 3 dentists, it'll take the full 12 months. So the problem with expanding NHS dentistry is nothing to do with what the local ICBs can do. It's our national contract, which has been in place since 2006. But this is where Alison in West Yorkshire has allowed us this year, for the practices who've got capacity, to provide more services so they can do 110%. In the West Midlands in Birmingham, the practices were told last April, yes, you can deliver an extra 110%. So practices put into position extra staff, extra surgeries to provide this service. And come about September, October, the ICB wrote out to everyone and said, oops, sorry, we can't do that. You're back to your 100%. You can deliver more if you want, but you won't get paid for it. So we are quite fortunate in West Yorkshire. The challenges we're facing at the moment is, in practice, as everyone knows, from April, national insurance is going up for employers and being put in at a lower rate, and the minimum wage is going up, so that will affect our wage bill in practices. The last April, the Doctors and Dentists Remuneration Board announced a 6% pay rise for dentists. That was in the salaried service, so the hospital dentists got that. Our contract isn't just based on the practice contract, so we didn't get it all. They said part of it is wages, part of it is expenses. So they said we could get the 6% for the expense for the wages part, but our expenses, they've not gone up as much. They've calculated, it's called a dental deflator so our dental inflation for our expenses was calculated at 1.2%. So overall, that's given practices a 4.6% rise when we've already had to allocate 6% to all our staff, the national insurance rise and everything else that are coming. And this was meant to be from last April. Practices still have yet to receive this money, so we've not received any of the pay rise from last April, and now we are approaching next April, and we've got no idea how to plan and cost for the following year's wage rises and everything else. The government has announced that there's going to be 700,000 extra urgent appointments, and they've been talking about this since way before the election. 6-7 months in, we're no nearer to knowing how they're going to deliver this, whether there's any extra money for this or whether it's going to have to come out of existing money. This is one thing in West Yorkshire. If other parts of the country ran their urgent sessions how West Yorkshire have set out, I think they'd have filled that 700,000 appointments within about 3 months. So what they're saying isn't really going to make a drop in the ocean. It's getting harder to recruit dentists into the NHS because NHS practices, our costs are going up, but the money coming in is staying the same or going down. So we can't afford to give the dentists the rates that they can get if they were working privately. But it's not just about the money, it's being able to treat the patient how they need to be treated rather than what the NHS will allow us to do on the patient. We've been waiting for contract reform. The new contract was introduced in 2006. In 2008, it was decided it wasn't fit for purpose, and we've been in countless pilots and prototypes, and now we're, however many years, 13, 14 years since there's been talk of contract reform, and we're nowhere nearer. We've had a few tweaks at some contracts that have nationally, but there's been no major reform. I think West Yorkshire have been doing quite a good job with us locally, which we're grateful for. Otherwise, a lot of practices that I know that aren't happy. We don't hear about dentists going on strike, how GPs might threaten, or the hospital doctors. NHS dentists just decide they can't run this as a business, so they hand back the contract. And this is where I think the public get confused. They think NHS practice has gone private, or they've taken all this money for the NHS and the NHS facilities and the building and the materials, and they've gone private. No, all NHS dental practices are a private company, an entity that I'm a private person, that I commission services to deliver for the NHS. The NHS don't pay any of the building costs, any of my material costs, wages, refurbishments, investment in the practice. And this is the thing, since 2006 the new contract came. Before that, the local NHS teams or PCTs would, every few years, they'd be writing to practices to say, well, they've got some capital money. If you're delivering NHS services, we'll help you invest in a new chair or buy new sterilisation equipment or computerisation or digital radiography. Since the new contract has come in, there's been no extra help for practices to invest. So all this investment has got to be done through the existing contract or by doing private work. And at our practice now, we have a private dentist who is in effect subsidising the work that the NHS patients are receiving. And one of the only reasons I can stay NHS, and I'm dedicated to the NHS, our practice provides 96% of its care to the NHS. And the only way I can do that is because I bought my practice 20 years ago. If I was wanting to buy a dental practice now and be an NHS practice, I'd find it very, very hard. So, thank you.
Thank you for that. I think we'll move into questions. So if you want to speak, please indicate. I've got a few comments and a question to start with, but I'll try and look out for people who are indicating as well. I have to say, I'm a little bit... So I understand these challenges, I really do, and I understand 100%. I think we should be supporting you on the need for contract reform, given it was needed in 2008 and it was agreed in 2006. I totally get that. I also understand there's a bunch of headwinds around additional costs. But I think it's difficult for you to... I find it difficult when you come in and say, minimum wage increases are going to be difficult, because I suspect that's not a big part of your wage bill. At least I hope it isn't a big part of your wage bill. So I think that's probably... and then the other thing you said, which surprised me, was that you said you don't get any money for the expenses of running the building. But then previously you'd said part of your contract is for expenses. And so that's not quite consistent. And I get what you're saying. But I think we do need to be aware there are definitely challenges, but I think my challenge back to you is to not overplay the hand. I guess I've got two comments and a question. So the first one is my observation, and obviously it's a small sample of my family of people I know, is that the service I get from my NHS dentist has gone down. So 5 years ago, if I went for my annual checkup, my teeth would get checked. They'd scrape off all the plaque off my teeth, and I'd be on my way. And now they basically count my teeth and then send me on my way. And I say, so I guess from our perspective as residents or as clients or as consumers, it's difficult to hear that it's really hard for you in the dental practice when, I guess from our perspective or the residents' perspective, you see things getting worse. So I think that is hard. I think the other thing I saw in this paper that I think we really need to highlight more is on the appendix data, which just on the last page, on page 30, it says, unlike other medical services such as GP practices, dental services are not commissioned for every resident, as there are a number of people who choose to go private. And I think this is shocking and it should be highlighted more. So the idea that it looks like something like half of all dental practice is actually commissioned to be done by through the NHS is shocking, and it just creates a vicious circle. So people who are getting a poor service, who have just enough money to pay for private, are going to go private because they want good teeth, good dental hygiene. You know, that's really shocking, and I think we should really highlight that. And I read that and I just think that's appalling, and I think it's something that the government should take up as a matter of urgency, and we should move towards a fully funded system. I can't imagine being in a situation we as a society would accept, a situation where half of GPs were funded. It'd be mad. And so that's my two comments. And then my question is, on 2.2 is so we're talking about we want an improvement, and we've all talked about one improvement. It's really important, and I guess what I'm after is like really tangibly how are you measuring improvement, and what do you know? So if you came back in a year's time and said this is what's better, how would we know what we're trying for? I know I've probably ranted a little bit there, so I appreciate that as well, but that's my question in terms of improving services. But I'll let Alison come in, and then Jane, if you want to come in as well. And I'll also bring in, I've seen you, Jonathan, as well. Yeah, thank you.
Firstly, just to say about what the point was about the funding for NHS and, you know, the standard that we can only deliver to part of the population. We totally agree with that. We would love to supply really good quality NHS treatment to every single person in the population, and they all have right to have NHS. We just don't have the funding to be able to do that. And if we did, we would welcome that as a dental team, most definitely. So yeah, we're totally on board with that. Just coming to how we monitor services, the dental team has grown, like I've put into the report recently, so we've now got data coming through which we didn't have before. We don't have one dental system like medical do, so we don't have one like system one and EMIS. We have many dental systems that all different providers use, so getting the data from that we have to use the BSA. They pull the data off FP17s that the practices put in. Now, that contract's monitored mid-year, and most practices have to attain 30% of their contract for primary care through that year. Last year, we had a large number of practices not hitting that, and certainly through COVID years, that was definitely seen that practices couldn't attain that. This year, we had 17 practices in West Yorkshire who didn't attain the 30% at mid-year. So that in itself, we can see that practices are actually delivering well. The fact that they can deliver to 110% overall, that is huge. We've got, you know, a large number of practices delivering that now across West Yorkshire, not just in Leeds. So the fact that they can deliver that, and we know they can, and we're working with them to monitor that through the FP17 data, is absolutely great. As Munaf alluded to, we've put lots of different provision into Leeds, working with inclusion health groups, and we're trying to do that to hit every single person out there so they have some access. We're not saying it's the be-all and end-all, because we certainly know that we would like to double all of those practices or triple them in most cases. But we're trying to meet the needs of those people in all the inclusion groups across that. So I think that is really important that we're monitoring that, and like the anecdotal evidence we've had, we had at Jane's LDN recently, we did a big presentation to our LDN colleagues on there across the trusts and the primary care and everywhere. You know, we had anecdotal evidence from patients on there which we can monitor, and it's lovely to hear that they're, you know, having the service that they think, you know, that they're entitled to, and quite rightly, you know, can get through some of the services that we've commissioned now. We would love to increase that. We'd love to get, you know, more out there. It's just very difficult when we've got a ring-fence budget. Thank you.
Yeah, and the fact that successive governments, and it doesn't matter whether they were Conservative or Labour or whatever, they have never ever funded a universal NHS dental service for the whole population. It's only ever been about 60%. I don't have, unfortunately, any great hope that this government will suddenly find another 40% to put in the dental budget. So we're forced to try to make the service the best we can for the population that we serve. And we are trying to target services to address the most needy, really. So areas of greatest deprivation or the sickest patients. And it's all we can do in the circumstances. I was going to make another point now and I've forgotten it. I'll come back if I remember, sorry. Thanks.
Manu?
Yeah, just a few things that you mentioned about the minimum wage. The reason it's going to affect dental practices is a lot of our nurses currently are maybe £1 more than the minimum wage. the current minimum wage. So when the current minimum wage goes up, it's going to be virtually on a par to their wage. So they're turning around, they're saying to us, we're qualified nurses, so why should I work at yours and get 3 pence more than what I could get working anywhere at Tesco's or at the local shop? And it's less stress. I don't have to worry about getting needle stick injuries, abusive patients and these other things. So practices are going to have to put the wages up of the rest of our staff so that we can stay competitive and keep our nurses. And it is hard to get dental nurses who are trained and qualified and decent staff. So to keep them, we're going to have to put their wages up. The contract, 46% of it is, or 54th I think it is classed as expenses for the practice. That is not for capital investment of new chairs, but that's for your buying your dental materials, you're paying your laboratory for your lab work, paying the electric, the gas, everything else has gone up so much in the last few years, and for the government to say that our cost inflation is only 1.2%, I think is really bad. And when you're saying NHS practices, if you're going and they're just counting your teeth, you're doing a good job with your cleaning. Because if you had tartar that was causing a clinical issue, they'd have cleaned it. Now, this is the thing, on the NHS, we do not polish the patient's teeth anymore because that is classed as a cosmetic procedure by the NHS. Removing the physical tartar that's under the gum, if it is causing gum disease, we'll clean it off. But now, because of time constraints and practices haven't got the time to spend as much time with the patient, where we used to book out maybe 20 minutes for a checkup and a clean, now we're lucky to get 10 or 15 minutes for that time, in which time we've got to do you may think we're just counting, but when you come in, you have the joints checked, all your soft tissue glands are checked to make sure there's no lymph node inflammation, all the soft tissues are checked in the mouth. This is where I think it's bad that there's not as much access, because I have on a patient where it was a very small little ulcer that I wasn't happy about. I sent her to get referred. She was seen within 2 weeks, and that was a small squamous cell carcinoma, which left 6 months or a year would have been a much difficult thing to treat. So if you are in and out of there quick, it's because clinically you don't need something doing. And what patients think clinically is needed and what the NHS think is clinically needed are two different things. So, yeah, thank you.
Yeah, thanks for that. I totally agree. It's about what different people think is needed. And you're right. The polishing may be seen as cosmetic, but we as like people who come in as customers or clients, they don't necessarily have the same viewpoint. And so when you say your appointments were 20 minutes and now they're 10 or 15, that's the point I'm making. It feels like there's less service for the same, which is a problem. Okay, I'm going to bring in Jonathan next.
Thank you, Chair. Firstly, from what Councillor Venner said, we are still getting experience from people who are having issues with dental surgery, but we are seeing what we think is a bit of an improving picture, in that the number of referrals to and people contacting our helpline in relation to dentistry has actually declined over the last year or so. Which we think is a good sign, although we have got a lot more information on our website, so it might be some people are using that rather than actually ringing us. And I consulted John Beale, who many of you will know, who's our dentistry guru, and he did confirm that in terms of what is happening in West Yorkshire, since the responsibility for commissioning dental services has changed, has led to some improvements, and that West Yorkshire is looking better than some other parts of the country. So there are some positive signs there, but we need to be careful that that doesn't mask the fact that there are still a lot of people who are struggling to get access to dental services, either because they're not there or because they can't afford them. And that leads me to two questions that it would be helpful to get a bit more detail on. One is on page 29, where there is the list of the number of providers in postcodes. There's an incredible range there, from LS12 that's got 12 down to LS4, LS5 that don't have any at all. And I'm wondering what can be done about that in terms of commissioning, managing the flows and advising people, particularly where there are no providers, what they can do about that. So that's the first question. The second one is that we are picking up quite a lot of anxiety around the community dental service, which you mentioned earlier on is aimed at people who have additional needs in terms of their use of dentistry. And people are concerned that there are lots of people falling through the net, that service is not as comprehensive enough. So I know what you were saying about that now being reorganised and Bradford taking the lead, but what does that actually going to mean for people in Leeds who need that service?
Should I pick up that second point about community dental services? So I think it would be fair to say that there are 4 community dental services in West Yorkshire, and very small services, and we have found it very difficult to recruit to them because often dentists are working as sole practitioners, particularly in the case of children. And so we really welcome the move towards one West Yorkshire service, which will allow different places to really specialise, to provide that clinical leadership across the whole, and just have a much more comprehensive service. So we're in the process of moving to that new model now. In the meantime, we've started to do some goodwill work between the different community dental services so that we pick up each other's patients where we have that expertise. What I would say is I'm not aware of us turning people away from the community dental service, but acknowledge that sometimes people wait for long periods of time and therefore may perceive that they are waiting, there isn't a service. We were not in a position where we would turn people away.
Thank you. Alison, do you want to tackle the location question? Thank you.
Yeah. So, yeah, definitely from the data that we provided, there is probably an equity when you look at the where the practices are in different postcodes. Unfortunately, that's something we've inherited. We have like a ring-fence budget, and those practices are there, and they've been probably there for, in some cases for 20, 30 years, even, you know, from when I started in dental years ago. So, and we can't move those practices unless they come to us with a location change request, which quite often they don't because of the overheads of doing that. They're in premises and they stay there. So we don't have any money to go out for a procurement to put into other areas, so we don't have any money lying around. But if there is a practice that hands back some UDAs or a whole hand back, then we always go out and we look if it's a small amount, because we base roughly about 6,500 UDAs on a one full-time equivalent working in one practice. If a handback is only 2,000 or 3,000 UDAs, we wouldn't do a procurement just for that, because nobody would take a practice on for 2 days a week. It's just not cost effective. So we end up reinvesting those UDAs into practices that we've already got in Leeds, and unfortunately those are the practices in the area that's in the report. So the only way that we will be able to go out is by having an investment through National of Dental, and we would certainly welcome putting some activity and premises. We just work with what we've got, unfortunately.
Thank you. Super, thank you very much. Okay, Councillor Bromley.
Hiya, thank you for talking today and having this on the agenda. Qualified dental nurse here. Pleased to hear that the wages will be going up, but I appreciate that obviously individually that's not so great for the owners. But so I started in 2006. I have seen personally from a dentist in NHS sort of signing that new contract, realising what was coming. And I think that in terms of looking at this, it feels far too long down the line, and also for the fact that dentistry has always been sidelined. It has never been seen as a primary care need, and I think that having actually the understanding clinically that it is life and death at times, the fact that if you catch oral cancer, the fact that if you have an abscess that then needs emergency care, this is something that can be life and death situations, and it's not treated in that way by our health system. And so I agree that nationally that needs to be understood more than anything, and so localised, it's great that we can have good intention. But at the end of the day, if we want to attract NHS dentists away from private and into the NHS, we're going to have to make sure that we're drumming the beat that this is something that is essential and needed for everybody across our country. Now, looking at the interest of the parts in this document regarding how you reach out to communities, I wondered if we're making use of nurses that do train into oral education into schools, if we're facilitating that and making sure that that is being made as accessible to every school as possible. And also then providing the information for families, then going back with the access to dentist practice nearby, that they may be able to go onto a waiting list even if they can't be accepted immediately. And secondly, you talked about lining up GPs and GDP, which is so important, isn't it? And it's been lost for so long. In terms of, you mentioned like oral and soft tissue, but I wondered also the perio risk linked to heart disease, and so also in hospitalised. So are we making sure that they're being referred back for perio treatment, and that we have that relationship and that communication going forward as well? Thank you.
Thank you. Yeah, I'll just start first and I'll let Jane come in, but most certainly exactly what you said. Dental is so important. It links with medical on so many avenues. Jane's leading on bisphosphonates and cancer for West Yorkshire, and it's absolutely needed. Again, it comes down to what money we've got within dental and what we can do with it, and it's which priority comes first. And sometimes that's often a juggling act when we sit down and say what's going to be our priorities for next year and where we go, but we're absolutely committed to keeping the projects we've got going as much as possible. So that's the first point. The second is we've got flexible commissioning coming, and we've had that already, but we're looking at expanding that across Yorkshire and Humber. So practices have access to flexible commissioning both in access and health. So we've got our oral health practitioners in a surgery, that link with our health visitors and schools, and hopefully bring that in. Now that's expanding from the 1st of April, so hopefully when we sit here next time we can give you a better picture of what that's going to look like and the outcomes for that as well. Thank you.
Yeah, Alison's just covered it really, but thank you for that. And everything you've said is absolutely what I personally believe in and I'm working on. So hopefully if we are back here next year, we'll be able to give you an update on progress.
You were saying about nurses and oral health educators going out into schools. In Humberside, they are doing that at the moment. Teeth Team, I think it is, that goes out to quite a few practices, and they've done that locally. So I think with the dental services in Yorkshire and Humber, it is the 3 separate ICBs, but we've got one. Alison's sort of like leading the team, or there's a team that's leading it for the whole 3 areas. 3 areas are doing slightly different projects, and then once they've been evaluated, hopefully they're going to be rolled out. So hopefully if the whole scheme is seen to be successful, soon we'll be able to just roll something out similar in Leeds and West Yorkshire. Thank you.
Are you happy? Follow up.
I also feel like I should just apologise the fact that I'm not working right now as a dental nurse. I understand, but finding the qualified and keeping people long term is a difficulty. And thank you for all the work that you're doing.
Thank you very much for that, Councillor Bromley. Okay, Councillor Ritchie next.
Thank you very much, and it's good to read the positive things in the report, and to hear that Dr. John Beale recognises the improvements is really reassuring as well from my perspective. And it's also really interesting to hear the dentist perspective as well. You seem to be looking right at me. I'm not the health secretary. I wish I could do a bit more, but maybe that's me being paranoid. But it's good to hear that. I do like it when people tell it like it is. I think that's really important, even if it might be uncomfortable. I agree as well with the need to increase the wages of the dental nurses, and it's great to have the expertise of Councillor Bromley, of that lived experience as well. Some comments on the report. And it's good, I should add the homeless service, actually hearing that, about that, put to life as it were, really helpful as well, powerful speech about that, so good to hear. Just on the report, at 2.3, the urgent appointments, and there's 24,000. Just as an elected member who often gets people coming to me saying, I can't get a dentist, How do people access those appointments? Is it through the 111 perhaps, but you'll answer that, I'm sure. The second question is around 4.1 and the dental activity rate at 86.2%. Could you just give me some understanding of that? Because then going back to 2.5, we've talked about the additional 10% activity. So I'm reading the under-providing, if I'm understanding it right, but then we're also over-providing. So an explanation of that would be very helpful. And the final thing is around the education programme, which is mentioned in the conclusion, so via schools. Councillor Bromley also mentioned it. I'm aware as a EYFS link governor that promoting health and well-being is one of the key aspects of the that's early years foundation school governor, and some schools certainly go through teeth brushing. Is that right? Doesn't sound right anyway. Do we know if that is common across all schools? Because clearly that is part of the important education, isn't it, about using the toothbrush correctly and what have you. Thank you.
Okay, I'll try and do what I can remember, so apologies if you need to prompt me. The first one about urgent appointments, I'll go through that one first. So we've got a few avenues where patients can access urgent care. The first one we use is through our 111 service. So patients access 111. They are clinically assessed. If they're appropriately needing an appointment, they would be directed to one of our dental primary care centres across West Yorkshire, and then they would have their appointment there. Sometimes they're giving self-care advice on that appointment and told to contact their own dental if appropriate. If it's anything where it needs emergency treatment, such as swelling, radiating up to the eye, something like that, then they would be directed to A&E department. We've then commissioned additional appointments through our investment plan. So practices then deliver a proportion of dental appointments. They use access for that. So again, it's done through 111. So they would be given appointments, they're clinically assessed, and the practices can say ring 111. They will be clinically assessed, and the practices offers them 3 appointments. And then what we do follow-on treatment from that. So if they're needing a root canal or some further work, if they've got an abscess or something, then they would be invited back to have that work done in that session that we've commissioned. The third avenue is we've got PCT old contracts from ages ago where we've got urgent care in their contracts, and it is just purely to see them for that one episode of urgent care. So we've got those dotted around as well. We're working with those practices to bring them in line so that we can monitor access, because it's very difficult just because of the old contracts that they were on. And then we've also got practices which we've recently done where we've actually twisted under flexible commissioning up to 20% of their contract to deliver urgent care sessions. So within a session, they would see, again, patients push through from 111. We would see them and then follow up treatment, so to get them clinically stable again. I think Jane leads on urgent care for us. Have you got anything to add?
Just to say that at the moment we're undertaking a review of all urgent care. This will be right across Yorkshire and Humber, not just West Yorkshire, and we will be recommissioning services for 26. So we are looking at everything really at the moment. But yeah, Alison's outlined where we are now.
Thank you. I think we went to 4.1, is that correct as well, for the present position on adults and children regarding appointments availability, is that correct? Yeah. So latest data regarding dental activity delivery rate in West Yorkshire, on average we're delivering 86.2% of contracted activity compared to England 83.3%. This is lower than what we'd like. We are looking at common interest, like we'd say, but again, I just bring it back to the ring-fenced issue of money, where we have to try and accommodate everybody within that amount. We've got a dedicated amount of funding to our practices and to community dental, to IMOS and special care, and without the extra funding we are very, very limited to what extra we can do. And although we may change the playing field and invest somewhere else this year or look at being innovative about how we develop services, we've only got that ring-fence money. There's no additional money. So it's prioritising and where do we put it, because it's very difficult to decide.
Yeah, I think you were asking about why 86% is delivered and not the 100%. What we've got is some practices.
Correct. It links into this 2.5.
What we've got is, like at my practice, I'm fully staffed. I'm the lead dentist doing NHS dentistry, so I can do a lot of work. Alison was saying an average dentist, 6,500 units is classed as a full-time dentist. When the contract first came out, it was about 6.5, 7. I think Alison's being very optimistic to think a younger dentist, newly qualified dentist, is going to do 6,000. We're lucky if the younger dentists want to do any NHS dentistry, or if they do some, they want to work part-time, 3 or 4 days a week, and do less intense, so they don't not seeing as many patients as, say, I would see. Now, because of that, some practices, like my practice, I hit my contract every year. Some practices, if you've had a dentist go off on maternity, or you've had a dentist off sick and you've not been able to recruit someone to fill that position, you're not going to be able to hit your contract. Other practices where they may be on a lower contract value, they've got high expenses, they can't offer the dentist the same rate as what another practice could, or they're not in a nice area where the younger dentist doesn't want to go. So rather than all practices aren't delivering, you've got a few practices where they have problems with recruitment, and because they can't recruit into a dentist to come and work for them for the NHS, they don't hit their contract. So that's where we've had the under-delivery there, and why you've got some practices that can deliver 110%, and I've got other practices that are crying out to want to double their contract size because they've got staff and they've expanded, but there's no facility and there's no provision nationally or locally for practices to expand more than what contracts we've got at the moment. Thank you.
Thank you. That explains it perfectly between you. Thank you.
Thank you very much for that. Okay, Councillor Anderson next.
Thank you, Chair. Just a few things on some of the report. 3.2, it says this was completed in May 2022, but then it says it will inform, what does it, hang on. It will inform the principles that will underpin the strategy. So that was nearly 3 years ago. So is it informing, or has it informed, or is that just a mistype in that? In 3.3, there is a bit about prevention in the report later on, prevention schemes. Who's doing this supervised toothbrushing? I hope it's not teachers, because if kids can't brush their teeth by the time they get to school, I'm afraid we need to do something about that and start this a lot earlier. And you know, we need to get some parental responsibility in place. Kids shouldn't have tooth decay when they're very, very young. It's really, really bad if they don't know the importance of not eating sugary things or sugary drinks and so on. And the other comment is 4.4. Tooth decay was still the most common reason for hospital admission in children between 5 and 9 years old. These children, have they actually seen a dentist, or have they not had a dentist? And the third bullet point in the same paragraph, 4.4, variations in decay-related tooth extraction rates, 405 per 100,000 in Yorkshire and the Humber, compared with England, 236. That is a massive, massive difference. So what are we not doing here that they're doing in the rest of England? Thank you, Chair.
Okay, thank you for that. Just going back to the typo, the oral needs assessment is what we refer to. So I think that was just a typo, so apologies for that. But that has been informed, and it's something that our public health colleagues have written, and they did put the details into this part of the paper. So apologies for that. So I probably might not have all the answers that you wish today, but more than happy to share those after the meeting if you wish. Regarding the toothbrushing element, We haven't directly commissioned anything toothbrushing wise in West Yorkshire, but we do have the 0 to 17 programme which we've been running, which focuses on those children in deprived areas, working with schools and health visitors to meet the needs of those. It's certainly not teachers, it's most definitely dentists and dental nurses and oral health champions going in and supporting that. It's something that we are looking to develop at the moment. Again, it's ring-fenced by the money, and I'm sorry I keep coming back to that, but that is basically the crux, because we would love to do this and get them rolled out a little bit more. But where we do have these 0 to 17 schemes, it is most definitely dentists delivering that. So look, sorry, could you just repeat where the last part was?
4.4.
4.4.
Victoria, do you want to come in, and then you can come back, Alison, if you want to.
Yeah, that'd be great. Thank you.
Thank you, and thank you, Chair. Just to briefly add, as my colleagues just referenced over the table, we work really closely together with our ICB colleagues from Leeds City Council Public Health team, and we do have a children and young people's oral health group that meets, and that group is developing an action plan. So we're more than happy to share that if people are interested to see what's in the action plan. The Leeds, because we have a Leeds Healthy School programme in the city, the oral health very much part of that Leeds Healthy School programme, and it's my understanding it's absolutely not teachers that are doing it, it is oral health champions and others, but more than happy to provide further detail on that. And the other thing that has been referenced but feels really important is, as you mentioned, Councillor Anderson, there's a lot of work that goes on before the children get to school through our public health integrated nursing service, so essentially health visitors. Now, we have some short-term funding from our ICB colleagues to support more of this. Clearly, there's an issue of what we do as a city when that funding runs out, and there is something about making the most of the limited funding we have within dental health and the limited public health money we have together to make sure oral health is still a priority for our 0 to 19 service and for the Healthy School service. But I mean, there is great work going on, but we could always do more with more resources. Thank you.
Yes, and just to say that from April 1st, we're launching a new flexible commissioning scheme, which is access and prevention. So that will mean that practices use part of their contract specifically for access and prevention. And we are acutely aware of the very long general anaesthetic list for children. And this is why we work with the local authorities in terms of preventive programmes. And part of the flexible commissioning programme will be to tap into that and to promote our oral health champions and possibly some outreach as well. So, yeah, we are working very hard on that. Thank you.
I just wanted to make a couple of comments in response to Councillor Anderson's question. The first point I wanted to make is that, like with all public health harms, there's a social gradient. So there's much higher rates of tooth decay and extractions and hospital admissions in areas of deprivation. And in terms of the statistics that compare West Yorkshire to the rest of the country, obviously in cities like Leeds and Bradford, there's really high rates of deprivation. You'd probably get a more accurate picture of how well we were doing if we were compared to other core cities and other areas with similar demographics. I think to address that, as Victoria said, there's really excellent work that happens jointly with public health and partners in dentistry. And there's a lot of cross-council work. For example, I'm bringing a paper in the next couple of months to Exec Board around, jointly between Public Health and City Development, around advertising of high salt, high fat, high sugar foods, which is also linked to childhood obesity as well, which also has a social gradient around deprivation. Similarly, our library service did a really excellent project where they had a toothbrushing story and were giving out toothbrushes in the library. And I think for some for populations where, for various reasons, they're struggling to access dentistry, I think that kind of community initiative is really important. and services going out to people in their communities. So thank you.
Yeah, thank you for that. Interestingly, we've been looking at this at the Joint Health and Overview Scrutiny Board, which is the West Yorkshire-wide Health Scrutiny Board, the dentistry bit. One of the things that they've talked about is the fluoride in the water. I know that's, in some circles, controversial thing, but I think it's much more common in other parts of the country. I don't know if dentists have a view about whether that's part of the gap. I saw you wanted to come in anyway, Manu, so there's a cue.
Yeah, I think in places like Birmingham where they've got fluoride in the water compared to Manchester and Leeds, the kids have got a lot less decay just from the fluoride there. And I just wanted to say, you talk about children learning to brush their teeth before they go to school. Yeah, it would be ideal. Now, the health visitors do have access to refer children who are ideally before they've got teeth or when they're just starting to get teeth into the flexible commissioning practices. And myself, we are a flexible commissioning practice and we have been accepting kids. So every month we'll get a couple of referrals from the community, not the community, the health visitors and is it the maternity nurses? The people who are going out to see the newly born babies and their parents. And rather than just giving them advice, they're giving them the option of being seen at a dentist. So the people who are taking up that service are getting the advice at the correct time, so hopefully we're going to avoid doing work. I always think prevention is better than filling the holes after. It's better not to get them. Thank you.
Thank you very much. Yes, prevention is always a good thing. Okay, I'm going to bring in Councillor Rowntree next. Thank you.
Thank you, Chair. Thanks for the report and thanks for coming in today. Particularly interested to hear from the dentist. I'm not sure if I heard your name right. Munir, is it? Monash. Monaf, I beg your pardon. It's yeah, very, very good to get sort of hear your perspective on the your experience of the NHS contract, and that was very instructive. I think actually I had a few questions for you, which my colleagues and your previous answers have covered off, but something I'd like to raise with Alice, I think probably with Alison I could. I do have a bit of concern about the table on page 29 and the stats there. And I'm just wondering, because when we talk about, I think the heading is distribution of dental contracts, yes, now obviously a contract isn't the same thing as the location of a surgery. And I'm sort of aware that we're saying there are no providers in LS4. My NHS dentist does in fact have a surgery in LS4. So I'm wondering here whether this may be giving a misleading impression if it's based solely on where contracts are registered as opposed to actual premises where the dentistry is done. Thanks.
Yeah, you're quite right that a contract is sometimes obviously different. Unfortunately, my colleague Martin Ramsdale isn't here today, but he in public health and he provided that information, so I will check that and come back to you. Thank you.
Okay, great. Thank you for that. Councillor Richard, did you want to come in again?
Yeah, sorry to jump back in, Chair. I just wanted to go back to the point I made about early years and the promoting health and well-being, and Councillor Anderson's comments as well, because what I found when I visited my school is that, of course, there's breakfast clubs, they're eating fruit, maybe toast as snacks. So following that, the teaching assistants usually will promote good health by cleaning your teeth when you've eaten. So I think that's a good thing, and it is part of the Ofsted best guidance as well in the early years practitioners manuals. So what I was asking is if that's common throughout the city, but that's the context behind it rather than half an hour's lesson on brushing your teeth.
Thank you very much. Okay, I can't see anyone else indicating to speak. Do you want to come in again as well, Councillor Money? Yep.
I just wanted to come in back on and talking around significant changes being made, and we were discussing earlier as well perception, and I feel from my experience that so much is based on sorting out these UDIs and making sure that we're not getting to a point where we're putting people under so much pressure that they just physically want to move away from that work in any way possible, shape or form. And that all the other side of it, that then there is a sort of an immuneness to recognising how much stress it is and pulling back from maybe ideal decision making that could be done, and so to make it basically viable to do every day as a career and as a job. So I wondered, what is your feeling as well, based just nationally in that decision making on UDAs and how things are going ethically forward for practitioners, and that how we then communicate that in a perception form to patients, that maybe the soft tissue examination is more important than putting polish at the end, and so that we're not run just by perception, but actually by what is clinically the best thing for people out there.
Yeah, absolutely agree. It's a sort of public health campaign is what you're thinking of, I think, isn't it? Yeah. Yes, I think often we're just so busy doing the job, we hardly look up, do we? Yeah, I don't know how we'd go about it, actually. Yeah, I'll have a think about that one. Yeah, get back to you on that. But very good point, very well made, thank you.
Do you mind if at some point I was to get in touch with you on that to just discuss and have a chat?
Absolutely,
more?
Yeah,
Okay.
Brilliant, yes, love to hear from you. Yeah, I'll make sure you get my contact details.
Great, thank you. Angela can share them, that's fine, because she's invited you, Jane, so that's great, good. Okay, just some closing remarks on this section. So I think it'd be really good if we, as a board, write to all our council nurseries and ask if they're doing toothbrushing as a start. So I think the point about starting early, younger, is better with toothbrushing, which is Councillor Anderson's point. I'm sure my children certainly learnt to brush their teeth, obviously at home, but also at Two Willers Nursery, which is a local nursery in Beeston. It'd be good to check that's happening across certainly our council estate, because that's where we have the most influence. And I also think it's worth noting, and the belief of this board is that there should be a dentist contract reform. Unless anyone disagrees with that, I think that's nods. And I also think the point around the number of UDAs, using acronyms there, sorry, but the amount of dentistry is funded is too low, and I think that would be a point I think this board should take a view on. That'd be my view, and unless anyone objects to that, I think we should make those 2 points. So on page 30, basically only half of the UDAs are funded, and that's not, in my view, that's not good enough, and I think our board should say that as a health board. It's something that is about the health of our city, and if everyone's dentistry was funded through the NHS, more people would have healthy teeth. I think that's a statement that I think we should make. Good, okay. Dentistry people, thanks very much for coming. I really appreciate your input. I know you work hard, and it is a really can be a tough job, but thank you for coming today and engaging in the board. Obviously you're welcome to stay and listen, it's a public meeting, but equally if you've got to if you've got to get your 7,000 UDAs by the end of the calendar year, crack on. Really appreciate your time though, so thank you very much for coming. Going to move on to the GP section, which is pages 33 to page 58 in our paper. I think Helen will be. Oh no, Kirsty is speaking. Just to say, you can assume we've read the paper, but if there's anything specifically you want to highlight, over to you. Thank you.
Great, thanks very much. And it's hard to follow that because I don't have some of the necessary examples. The homeless example, again, really great to hear. So, yeah, Thank you. It's a good opportunity to provide an update on how we're progressing the Access Recovery Plan. It's almost 2 years since that was first published, and access obviously remains a real key priority for us at the ICB, just in terms of quality of service and obviously experience of patients as well. I suppose what we've tried to highlight in the paper is that we feel since the last update that improvements have been made, but that by no means that we're complacent about that there's still further improvements that we need to make. I think if you look back at the aims of the Access Recovery Plan, which was about trying to stop that ATM rush and patients knowing on the day that they contact their surgery kind of what the outcome will be, how they will be managed, I think we have made improvements in that. Whilst the paper talks through some of the specific actions that have been taken place, such as rollout of new telephony systems to improve that kind of functionality and again, patient experience, we've also talked about use of digital, use of apps and use and kind of that increased usage that you can see in some of the data. I suppose the main focus that we've been working on with individual practices has been the implementation of modern general practice, which I think is a term that patients don't recognise, and probably to a lot of practices they don't recognise that term. But certainly from a national point of view, the aim is to move all practices onto modern general practice, which in reality is about patients being able to access their practice through any mode, be that online, walking through the door, through the telephone, and have the same experience and same outcome regardless of that mode of outcome. That mode of access. The emphasis is around patients having that structured information gathering, so being really clear around kind of what's the condition, so that can be presented to the clinician and then signposted or booked into the right service or referred on where possible. It's not about non-clinicians providing that triage, but that robust process for ensuring that the right person sees the patient for the right condition. The emphasis is really on that parity of access. So I think, again, we've had pushback or some challenge around patients feeling that digital is the only way. The emphasis has absolutely been about trying to improve those digital routes to free some of those other routes up for those people who can't use digital, but recognise that there's still more that we need to do in terms of that accessibility, reducing some of those barriers and obviously supporting some of our patients around digital exclusion, etc. When we wrote the paper, planning guidance hadn't been issued, so I suppose the key update to provide board is that access remains a priority nationally. So within the planning guidance, very clear that access, improving continuity of care, continues to be a priority for 2025-26. Specifically, it's been reiterated that all patients should know on the day that they make contact how their request is going to be handled. There's more emphasis on tackling that unwarranted variation, so really getting into the detail around why different practices, different patients experience different things. Clearly, one of the outcome measures, or one of the only outcome measures that's kind of been signalled around general practice is about patient experience. So looking for that improvement this year on patient experience, and fundamentally trying to move general practice from a reactive to a more proactive care. So how can we improve continuity of care for patients? How can we ensure that patients don't have to wait till they're ill to make an appointment, that we've got better call recall systems, etc. And again, another fundamental priority is kind of that use of the multidisciplinary team. So we can see through the data in the paper that the practice team has continued to grow since the last update we provided, and we still need to do more work around ensuring the kind of acceptance of those roles from patients and the public is understood. And I suppose my last point is really just recognising some of the challenges that we've got. So I think colleagues alluded to strikes. Just to be really clear, general practice is not striking. There is collective action underway, which is very different from industrial action. Practices need to still fulfil their contract, but may give notice to stop or cease unfunded or unresourced workload. And that's because the general practice, the BMA, is in dispute with the government around their contract deal. So there are some challenging conversations in terms of our general practice colleagues across the city. They are challenging some workload shifts that are being perceived. So it's just to be aware of that context that we're working on. But overall, there has been some improvements. We know that there's still some further work to do. We're delivering around 20,000 appointments every day, 70% of face-to-face. I think it's important still to highlight that because I think sometimes we still hear around those challenges about access to face-to-face appointments. But again, I think we've seen that trajectory change over the last couple of years. I'll stop there and hand over to questions.
Thank you very much for your report. I thought it was really helpful and enjoyed. There's definitely some positive in there, so it's definitely improvements versus where we were. There's a lot of green on 8.7, which is nice to see. I don't know if colleagues have questions, but I'll bring you in. I think I've just got 2 comments to start with, and the first one is I think the pharmacy first approach is really good. My comment would be that it'd be great if you could find a way to increase the speed of access to a GP if you've done the pharmacy first approach. That's just a practical recommendation. I just think then there's a benefit to it. So if you go to your pharmacist and they say no, I can't help you, and then you've missed your 8 o'clock phone call for your GP, so I think that would be really positive. And then the other thing I think is just is a context. When I was looking at this report, I was searching for how many GPs we have as a country versus other Western nations, and we're low. And I guess there's still a bit. I do like the multidisciplinary stuff. I think that's really strong. But I still think we probably need to nationally do more to encourage people into a practice GPing. But I think that's got to be through making it a more attractive offer, as the old family doctor was. Okay, I'm going to start with Councillor Buckley.
Right. Yeah, thank you very much. You mentioned at the start in the national context about the general practices, and the collective action is not the same as industrial action, but does mean that practices may stop or reduce certain work that is unfunded or insufficiently resourced. What kind of work is insufficiently resourced or unfunded? That's my first question. Then the next part is 2.3, where you go outline the increased investment. It also confirms a focus on reducing bureaucracy. Can you give me an example of that, please? And then the other thing I was looking at, 3.5 we're going on to, where you said in 2023-24, 58 practices had got the robust processes being conducted by 58 practices then, and only 6 practices in 2024-25. Why is that, please? Thank you.
I'm just going to give Kirsty a break and do the unfunded, under-resourced question. The general practice contract is extremely vague. It basically says, do all the things you need to do to look after your practice population. A lot of things have changed over the last 30, 40 years in terms of all of the healthcare systems and all the healthcare processes. And there's certainly a perception and probably a reality that many things that would have been done in secondary care, in hospital settings, are being asked to be done by primary care. Now, that's because secondary care, it didn't necessarily need to be done in secondary care, but it always was. So one of the things that people are pushing back on are, for example, the consultant says, I've seen this patient, could you please sort out A, B and C in primary care? Now, primary care is saying, well, if the consultant says they want it done, the consultant should organise it. Or I've seen this patient, I think you should prescribe X, and then leave it for the general practitioner to prescribe. Or pathways where there are lots of tests before you refer a patient. So those kinds of things which are custom and practice, almost certainly better for the patient in many circumstances, but not always, then create a tension about is it a resource shift? Is it the right resource shift? Has it been negotiated? Has it been funded? So a lot of it is those kinds of things, and some of them are things where actually it would be safer to do it a different way, but it's just become a habit. And some of it is where we really could do it a different way, but there's a perception of resource shift. The other example will be, you'll hear people talking about advice and guidance. So it's a strong push to ask for advice rather than make a referral, which is obviously great for the patient's perspective, but is not without work for general practice. So it's those kinds of examples where there's a perception that it's work that's come into general practice latterly. It isn't a core part of the primary care offer, but it's extremely grey, and different places do it differently. The other thing is where we pay additionally for things like shared care, where it's a specialist drug, but it's supported and monitored in primary care. There's a tariff for that we've negotiated over the last however long. There's a question about whether the rates we pay really match up to the amount of work that it is for general practice. So it's those kinds of things, but it is, as colleagues have said, the national contracts are the context in which we operate, but we also operate within local relationships, local history, local custom and practice. And so it's the cusp between history and culture, I think, probably would be maybe a way to describe it.
I'll just come back on some of the other points. So the point about, I guess, not many practices taking up modern general practice this year. I think, as always, we've probably got those who were kind of keen to change early on. I think this year we've probably, I think some of the collective action engagement has probably affected some of that. What we have done, given the planning guidance have indicated modern general practice is here to stay, we've kind of gone out as a last push before the financial year end to say there's this opportunity around this resource for this year, come and talk to us. What we don't know is what the resource will come with the national contract next year, but obviously what we're trying to do right now for those practices that haven't engaged so far is kind of do some work. We know, and I suppose just to, not all of those practices have not done anything around improving access for those patients. I think there's probably some lack of clarity about assuming there's a set way of doing it and it's only that way, which is not. The model can be flexed for your practice. So I think we've just got to work out some of those myths for some practices as well. But yeah, it's definitely our intention to try and increase that number on that list there. I think there was another point about reducing bureaucracy. What does that mean? You might have heard the NHS has been doing something called the Red Tape Challenge, which is very much trying to look at opportunities around reducing bureaucracy up and down the country. We're waiting for that report to be published. Some of the previous recommendations which were in the Access Recovery Plan were definitely around some of the things Helen's mentioned. So, if the consultant this will be a bad example, but respiratory might have seen the patient and want to refer to cardiology. Sometimes that goes back to the general practice to refer on to cardiology. It's reducing some of that. Why can't the consultant refer to the consultant? So that's. I don't think that happens that much, but certainly historically. I know Tim's going to kick me later. But yeah, it's those kind of reducing bureaucracy. If we can streamline processes, then that's better for the patient, frees clinical time up.
Thank you. Super. Okay, bring in Councillor Blackburn next.
Cheers. First I'm going to ask an awkward question here, because if you look at 1.2, paragraph A, it says 87 practices providing services to growing register of population of 941,054, which, quite honestly, last time I saw figures for population of Leeds, it wasn't that large. So are we sort of treating people that don't come from Leeds.
Yes is the answer. So the people on GP.
Well, that would just mean being mischievous, that one. But basically, I'm going to speak here from experience. I've seen more than I want to see at National Service over the last 2 or 3 years. I think I can't escape from him, if you like. And what I've got to say, if you get to a certain age or you get something wrong with you, the service you get, both from GPs and from hospitals and that, is fantastic. And quite honestly, the number of times I get called to doctors for a blood test for this and a blood test for that and what have you is remarkable. So somebody in my position, at my age, with a couple of things I've got wrong with me, we're getting great access. But what I do find with younger people is they're still having lots of difficulty actually getting those initial appointments. And, of course, we don't know at that stage whether it's something serious or something not very serious. And I think we've got to do something about that. I find, I mean, one of the things is I use the computer a lot to contact my doctors, like with prescriptions and stuff like that. And I don't have to ring up, but certainly if you're ringing up to make an appointment, that service is, I don't care what practice it is not very good. And until we do that, I don't see that we can overcome that problem. But as I say, if they've already captured you with something, I've got to say the NHS is fantastic.
Yeah, it's one of the points I was going to make is sometimes we get challenged with around we're asking to use digital modes too often, and again some of the feedback that we get back is that sometimes it's switched on, sometimes it's switched off, and therefore that creates a further barrier for patients around you're encouraging us to use it, but then it's not available. And that is definitely one of the areas that we've got to improve over this next year. I'm interested in your feedback around if someone's actually getting through on the phone and then their experience is still poor in terms of being able to access an appointment. It's normally the opposite way around. So we welcome the feedback so that we can continue to address that.
Yes. So can we just after the meeting, Councillor Blackburn, can you let Angela know which practice, and that you can feed that back? Because I guess I personally find the opposite. Once I'm through, it's okay. I think there's been historically sort of difficulty with people saying, they don't want to talk to the person on the end of the phone, but increasingly they're very well trained to be able to triage you. So you can go back, Councillor Blackburn. Did you have a follow up?
I'll follow up.
Yeah.
What I'm going to say is, I've got to say, I have found, and this, on my own personal experience as well, this is after lockdown, it was terrible. Whatever way you did it, and the improvement that we've got since we got back to more normal life, although we're still not normal, are we? But as we have done, it seems to have improved. I'm not getting the number of complaints as I did do at one time.
Thank you. I'll tell you that's a comment. I think that's positive. Thank you, Councillor Blackburn. Okay, Councillor Rowntree.
Thank you, Chair. Thanks for the presentation. I've got a few questions here. I'll just find my place. Page 33, paragraph 1.2, the discussion about appointments. Are these GP appointments? It says within a GP practice. Are they appointments with GPs or all appointments in the practice of professionals? I get the impression it's the latter, but I just wanted to check. And then a bit further down, page 38, 311, the expression community pharmacy. I don't think this is as widely understood as a concept among the public. And I just wonder if it's something you think should be more promoted. Like, what specifically is a community pharmacy as opposed to pharmacy in a general sense? Then moving on, page 45, paragraph 7.1. The increase in GP FTE, it's increasing has increased recently, which I think we could be pleased about. But are there concerns about future potential shortages? So I'm aware that there's been a conversation nationally about a number of GPs or older members of the workforce, and retirement or early retirement is imminent. 7.5 on 47. The PCN workforce, now 23% increase, that's a huge increase over a single year. I'm just wondering, is this due to some sort of recategorisation or what is covered by PCN rather than actual levels of recruitment and an increase in staff? And very briefly, page 48, the WTE, I'm just wondering if that's similar to FTE. It's just an abbreviation I'm not familiar with. And then my last one, page 51, 8.8, the improvement, there's a mention of an improvement in scores there, and I'm just wondering by how much and what the baseline is, because the table is sort of a comparison with regional and national figures rather than what's got before. I'm just wondering what the extent of the improvement is. Thank you.
I might have lost some in the middle, so do come back to me. I suppose I'll take the two first ones, which are easy to respond. Yes, it's all appointments. It's not just general practice and practitioner appointments. So I think I'll make sure I amend that in future reports to make that really clear. The community pharmacy, this is your high street community pharmacy, and I would agree, I don't think this is well known necessarily. I think there's been some national campaigns, but I think there's more work to do to kind of increase awareness of some of the services that community pharmacy colleagues do offer. With regard to the workforce questions, yes, increasing general practitioner workforce. I think there is probably a similar comment from dental colleagues where we need the contract reform to make general practice a good place, vibrant, people want to work. I think what you might also see nationally is that we've got GPs who are qualified, so I don't think there's an issue about GPs not going through kind of training or anything else. I think it's the availability of roles once they've qualified that's the biggest issue, which links to some of the contract kind of reforms as well. In terms of the PCN and that jump over the last 12 months, I think in reality it's just about timing. I think the contract deal where we had the additional money to fund these roles, called the additional roles, I think it's found its feet, I think is the best way of trying to describe that, where people recognise the roles that they can fulfil within the team. I think the trust that the money's recurrent for people to go. So, and obviously the training's caught up so that there are people there to fill the post. So I think it's just probably a timing issue. We've obviously this year there's been from October a new role included, which is a GP through the additional role reimbursement scheme. It's for newly qualified GPs to support them kind of in their first couple of years out of training. So we are looking to maximise that resource as well to increase that GP workforce. And then, yes, fair comment, and so I don't have the figures to hand to show you exactly how they compare from the year before. I think selfishly, when you show this to some of our other ICBs across the country, it looks really positive. And I think for me, sometimes with access, we get kind of blinded by just can I access for an appointment, and actually what this is showing is that once people do get an appointment, actually the quality in terms of trust, being involved in decisions, and I think that's what really matters as well. But yes, I take for granted that you can't see the improvement necessarily from there. You can just see the comparison. So I will do some further work on that.
Supplementary.
Thanks, that's great, really informative. Can I'll just check the WTE, please.
Full-time equivalent rather than full-time equivalent, but yeah, effectively.
Super, thank you very much. Okay, Councillor Ritchie.
Thanks, Chair. Thank you for your report. It's one question from me. There's clearly been an increase in appointments, be it through the enhanced pro access or whatever, and an increase in GPs and other staff. And you've linked that per population. I just wondered if the increase in appointments accounts for the increase in population over that population growth over that time. So that's the question. I'm asking you to put another table in that, really annoyingly, but there you go.
I think it's a really good point. So yeah, we will definitely look at that. So I think we obviously attribute a lot of increase in appointments to the increase in staff, but actually, yeah, our population's increased, so we do need to be tracking that, don't we, to make sure that we're not stretching the service even further. So yeah, that's helpful.
It's just more to understand that it's a real terms increase, as we often get quoted and want to see, don't we? Thank you.
Thank you, Councillor Ritchie. Okay, I'm going to bring in Jonathan next.
Thank you, Chair, and thanks again for the report. Healthwatch is still picking up a lot of anxiety around digital exclusion, where people seem to think the only way they can make contact is online, and then they can't because the patches system has got switched off, as somebody mentioned earlier on. And I suspect what might be happening is that we're going to get to the point where those people that can use digital and find it really helpful, as I do, will get to kind of their optimum level. But there is a risk that we actually increase digital exclusion because there's a range of people who either can't access the internet or don't have the skills to access the internet and don't actually get access to the information which says there are other ways of accessing as per modern general practice. So it seems to me there's a huge communications issue to try and make sure that people genuinely understand the different ways in which they can approach and can then measure their experience against that, because I think we're in a potentially stuck situation at the moment, and that seems really vital going forward.
I would agree, and I think I suppose I just want to reiterate the points I made earlier around the focus has to be about parity of access. So I think the other elements in the planning guidance being really brutal with you are around ensuring we've got strong contractual arrangements and improvement methodologies. So I think we really need to work with partners across the city around understanding where those barriers are kind of being experienced so that we can target that support and that improvement. So certainly one of the, again, whilst we've had that confirmation that modern general practice is here to stay, we've obviously gone back out to engage those practices who haven't engaged so far, but our next step is also about reiterating what that actually means. So again, patients shouldn't be being asked to ring back, for example. Patients shouldn't kind of be bypassed certain things by using online, etc. So I think we've got to kind of do our bit in terms of holding practices to account for that bit as well. And I think there's more that we need to do in terms of patient engagement as well, in terms of understanding what does this mean and how can we access services. So yeah, I completely agree.
If I could just add, Chair, I think this goes back to the point that the Councillor made earlier. It's really helpful for scrutiny members and local councillors to be able to be aware of this stuff, and the public information is incredibly important, and the myth busting is incredibly important. So when people say it's fascinating, isn't it? People have two completely different experiences of the same practice in the same week, and we all know that happens. So I do think it is really interesting how variable people's experiences are of the same offer. But I think also the help of colleagues in reinforcing that you absolutely should be able to phone, and if you can't phone, this is what we ask you to do, and maybe you collecting some of those experiences, not to flood them, but just we maybe just need to touch base. And I think Health Watch's role in that also incredibly important. Like you said before, there is something about all the partners collectively supporting the public in accessing services, and I don't think we've probably maximised that enough, that public information. And it's not, and I think the more we say, and of course it is helpful if you use digital, people assume that means and only digital. But I think the intention is that those who can should, because then those who can't should be able to get through on the phone. So I think we need to explain why this isn't about stopping people phoning who want to phone. It's about people choosing the route. For me, to be able to put in a message and then not think about it is really, really helpful. For other people, that would be an absolute disaster. So I think it is any help that colleagues around the table can have in their constituencies, in their, you know, with talking to your members, really helpful.
Super, thank you very much for that. And yeah, I tend to agree with you. I think medical people prefer the online stuff. My wife's a nurse, and she's very much prefers to put in appropriate language on the chat device. Good. Okay, so I think we're gone through our questions on the GP section. Thank you very much for that, Kirsty. That's been really helpful. It's good to see progress. It's good also to recognise there's more to be done. So we're going to move on to the third section, which is elective care. And firstly, thank you, Tim, for waiting. Sorry, it's been a wait. I don't know if you've got any introductory comments, but as I said to Kirsty and Helen, you can assume we've read the paper, but you're welcome to make some introductory comments. Thank you.
Okay, thanks very much. Yeah, I will take the paper as read, but just highlight a few key points, if I may. And I think the first one I want to emphasise is to try and give some clarity as to what we mean by a waiting list. And apologies if this feels too low level or condescending or anything like that. That's certainly not the intention. But references to the NHS waiting list generally mean patients who have been referred in and have yet to start the treatment that they require. And that's a first episode of definitive treatment. We have lots of other waiting lists, so we've got patients who are on a sequence of treatments and who need subsequent treatments. They're not included in those numbers of patients on the waiting list. Patients who need diagnostic testing, patients who are on long-term follow-up pathways, patients who just need a review after their treatment are also not included in these numbers. So therefore, it's also the flip side of that is that one episode of care or a review doesn't necessarily mean that that patient will be removed from the waiting list. So an outpatient review that results in a patient being listed for a subsequent surgery or other treatment doesn't remove them from that waiting list because they haven't yet started that treatment. So you've got examples such as a cardiac review prior to a surgical intervention doesn't remove a patient. So it's important therefore to note that activity as such doesn't necessarily mean that a patient is removed from a waiting list. Also important to note that we have waiting lists for different specialties and they differ in terms of the length of time that patients have to wait because of the different capacity issues that we've got affecting different specialties in our services. So now I've said that sort of basic stuff, just worth noting that prior to the pandemic, LTHT had reduced the waiting list to the lowest level that I'd seen in my career there, of about 56,500 patients were on our waiting list. 86% and a bit of those had waited on that waiting list for less than 18 weeks at that point. After the pandemic, we saw a rapid growth in the waiting list. September 22, for example, we had 91,819 patients on the waiting list, so you know, not quite double, but not a million miles off. We did work really hard to try not to break that 100,000 barrier. There's that sort of psychological thing of staying before, you know, holding the line on certain measures is really important and incentivises our team. I've put in a section on clock starts and stops from page 61. Again, that's largely referrals into the trust that start an RTT clock and treatments or reviews that start that treatment that stop the clock. The referrals in are largely from GPs or another hospital for a specialist review. And those numbers put LTHT as the 9th biggest provider in England in terms of that volume of activity coming in and going out. The charts on page 63 show the size of that waiting list. First being the numbers pre, during and post the COVID-19 pandemic. And then it's a compressed scale, which shows the consistent reduction that we've seen over the course of the last year or so. Worth noting that July 24, we had an error in the data extraction. Because these are snapshot figures, a point in time, we can't go back and then correct that. But safe to say that line should be consistently sort of straight. In terms of waiting times, the average wait for patients on our waiting list is 11.32 weeks. So if you took all of those 86,500 patients that we've got now and average out the length of time that they've been waiting, it's 11.32 weeks. That puts us 21st in the country of 119 acute and combined providers. And about 65% of our patients at the moment have been waiting less than 18 weeks. Another key measure is the longest wait for our patients. Prior to the pandemic, we had we'd got down numbers of patients who'd waited over 52 weeks or over 1 year on our waiting list, down into single figures. More recently, our over 52-week wait numbers peaked in March 21, and we've now recently improved, and we're now at our lowest levels since December 2020. We are trying to reduce the waits for our longest waits to under 62 weeks. We were at 132 patients in December, and we will be reporting a further reduction in January on that number. That then becomes a small number of specialties that have specific challenges in terms of capacity or specific procedures that patient needs, that getting them into operating lists becomes more challenged. And just worth noting as well, for the 25-26 planning has been out, and that's been mentioned a couple of times, so the guidance that we use as to what we're going to do next year, we've been asked to deliver a further 5% reduction in RTT, and fewer than 1% of patients on the waiting list having waited over 52 weeks by the end of next year. We certainly hope to be able to do that. We want to be able to do that in an appropriate and sustainable way. So that 5% reduction, we want to see a reduction in the total waiting list number, not just the number over 18 weeks. So, we want to make it a bit harder for ourselves to deliver by doing both things at once. And I'll stop there, ask questions.
Super, thank you very much, Tim. That's really helpful. I thought certainly on section 4, that graph was very helpful in terms of where LTHT is relative to other hospital trusts, particularly teaching trusts, which one's just below it. But other than that, the teaching aspect.
Yeah.
I'll open it up for questions if members of the committee have questions. Sorry if I missed this, and it's an obvious question. Just in terms of people who are waiting for operations who may not be fit for an operation at this point, maybe they've got excess weight or whatever. Am I right in thinking that they wouldn't be in the waiting times?
Sort of. Sorry to be a bit vague, but some patients will be added to a waiting list. We know we've got a certain period of time, and they'll be advised to undergo a programme, say, to reduce weight or stop smoking, etc. We have a pre-assessment examination of those patients for their fitness for surgery prior to them coming in, which is generally a month or so before the actual procedure. If at that point they're unfit, then they come off the waiting list.
Okay. Councillor Ritchie.
Thank you for your presentation and report. So I'm guessing that the weights won't be uniformly spread across the different needs. So is there any particular areas that are particularly high and a bespoke approach to tackling those? The Health Secretary did announce, I think, 1.7 billion for elective, is it operations? when will you start to see the benefit of that? I'm conscious that sometimes announcements aren't all what they seem. And the other thing is, again, this may be anecdotal, but it did come from someone in the medical profession. And thinking about cataract operations, I understand that opticians now can refer directly, and this consultant who was telling us the story gave an example whereby the opticians don't use the sort of priority triaging that perhaps the NHS optician would do. So he gave the example where somebody went to the optician who didn't think they had a problem. They were told they had emerging cataracts. Within a few weeks, he was booked in and had the operation. But I think the NHS would have done it on a priority basis, so those that were in a more advanced stage with the cataracts would have got treated first. So there's a risk with these different referral routes that those most in need aren't getting the treatment first.
Okay, so absolutely correct that the waiting times are not uniform across different specialties. Our cardiology wait is the shortest in the country. Our neurology wait is the third shortest in the country. But we have specific areas of challenge. Examples would be head and neck surgery, so ENT. We have for quite a long time had long waits in spinal surgery. That was the area that we had waits in prior to the pandemic. And we've got some other services. The challenges there generally are a combination of increased demand, workforce shortages, and the challenges of therefore delivering increased capacity within our existing estate. We do things such as work with other providers regionally, but generally in those specialties, well, so spinal surgery, we are the only provider for West Yorkshire, for example, because it's a specialist service, and ENT is a national problem. We work with independent sector providers to try and get additional capacity where we can. We work really hard to make sure that we're not paying a premium rate for that capacity. And we work with our clinicians on what we can do to better streamline demand so that we're only seeing the patients that we really need to see, whether they can do additional sessions, but we have to be really conscious that we've got a small workforce, and if we just add more and more pressure to them, they're likely to become that sort of part of the problem by people who want to leave the service. So it's a fairly a fine balancing act across a number of specialties to work to really get plans in place that deliver over a longer term, and we have been successful at bringing those numbers down in all of those specialties. So I'm optimistic that we can continue, but it's putting a lot of work into a small number of areas to get the right results, really. And on cataracts, I can't comment specifically on the examples you've given. Within Leeds Teaching Hospitals, we have very clearly defined guidance on prioritisation of most urgent treatments. So, one of the problems with the longest waits is that tends to be the patients who require treatment the least urgently, and so we will prioritise other patients ahead of them. And if your demand coming in is more than your capacity you've got, you're pushing the waits out further and further. For cataracts in particular, we had, well prior to the pandemic, I can remember working with Helen on a Leeds-wide model for cataracts. Any qualified providers, so people can come into the market and offer a cataract service and deliver that and receive referrals direct from opticians. They have come in and provided a huge amount of capacity across the country and delivered a lot of cataract surgery. to the extent that our waits for cataract surgery are now very short, no matter what your level of prioritisation otherwise would be. I think that will probably lead at some point to some of those independent sector providers leaving the market, and some of that activity coming back to the NHS. There is that thing of, if you go from one provider to another provider, the waiting time may differ. We've worked hard across a number of services in Leeds to try and provide a one Leeds service, so wherever you go, you're going to get referred to the provider with the shortest wait, so we can equalise that to try and get a consistent service across the city.
Thank you very much for that. Okay, Jonathan, do you want to come in? And if anyone else wants to comment, please indicate.
Thank you, Chair. Thanks for the report, and it is certainly good to see that you're getting on top of some waiting lists. Healthwatch has been doing some work which we haven't yet published about the experience of people on waiting lists, and that wasn't covered in your paper, so you could see it statistically as good news, but there are still a lot of people out there who are being impacted, their lives being impacted by being on waiting lists. And some of the emerging findings from that are people having to chase up themselves and not being kept informed about what's happening, confusion when people are on 2 different waiting lists for different conditions and them not communicating with each other, communication being done digitally again and people not actually understanding that and not receiving text messages and things like that. So there's a range of things about how you manage people when they're on a waiting list that actually helps to mitigate the stress that they're under and their carers. It will be interesting to know more about going forward in terms of what plans you have in place.
So certainly happy to bring more on the experience work into future updates, but I'm happy to say a few bits now if that's okay. Absolutely accept that the communication with patients while they are waiting isn't probably where we would want it to be ultimately. We have over the course of the last year put in place a system where patients are contacted every 12 weeks while they're on a waiting list. There is a huge amount of work involved in that, but we now have an automated system that will send out messages to patients to try and give them that you've not been forgotten about, you are still on our books, we know that you're still waiting and we're being in touch with you, but to try and offer them a way back into the service if they need it. That is in the planning guidance for the coming year to try and improve the experience of patients on the waiting lists, and I do think there's a lot of work to do. I think the biggest thing that we could do to improve the experience of patients waiting is to shorten the waits that they have. That's not to say that we shouldn't bother with the other end, but I am really conscious that that is the biggest thing that we could do. Also worth mentioning that we are working to try and bring in a tool that will help us to prioritise patients who have different levels of deprivation. We know that the impact of longer waits are greater for those who are more deprived. Generally, so absence from work, for example, the inability to work when you have a condition being another. For myself, largely desk-based, if I had a mobility problem, I would probably still be able to work. For somebody who needs to be on their feet for their job, less so. So trying to do that is something that we're working on at the moment as well. Digital challenges, absolutely the point that's already been made during the discussions today. I'm really aware of some of the challenges for some people from digital communication. We have brought in a communication tool for patients called Digital Hub, which has significantly improved the access to information for some of the patients who were excluded for other means. So you can get massive type on this digital platform. You can get instantaneous translation and access information in multiple languages. So it's a balance of trying to make access to information the best for the patients rather than saying it's this model or nothing kind of thing.
Thanks, that's helpful and good to know that you're doing that. Just to make the point about how important the accessible information standard is in all that, in terms of making sure right at the beginning you actually know what people's preferred form of communication is. And I know LTHD is doing quite a bit about that, but I just wanted to log that.
Yeah, and gaining that information right from the outset is one of the challenges, isn't it? So thank you.
Great, super. Thank you very much for that. I can't see anyone else indicating. So thank you very much, Tim, for that. That's really helpful, and thanks for taking the time to write the report. I thought it was really helpful for us to see. I think Jonathan's point about patient experience is something that we'd definitely be interested in the future, and I think it's a really important angle to take. So thanks very much, and thanks for the other people who've come today for this item. I thought it was really helpful and an interesting discussion. Okay, we're going to move on to item 9, which is the work schedule. So firstly, the schedule, there isn't much in it because we're in February, near the end of the municipal year, and so there's only one more meeting scheduled, but obviously there could be a call-in or something, so you never know. The other thing is, I know you only got it yesterday or the day before, but there's a note that around about our working group about children's and adults neurodiversity assessments. If you've had time to read it, I'd like to approve it now, but if not, if you want to say let's knock it to next meeting, that's fine as well. You happy? Councillor Kidger's happy? Yeah, okay. We're happy, so we'll take that, and I think that'll make it a public document formally, so that'd be good. Any comments about the work schedule? I can't see anyone indicating. Super. So just thank you for your time today. I know it's been longer than planned, but that's because we had the LGI item, which I thought was important to talk about, and everyone engaged in it in a constructive way. So thank you for doing that. So with that, I'll close the meeting. Thank you very much for your time, and see you next time. Thank you.